Okay. So let's welcome everybody again. Good evening, everybody. Just want to start off with the bracha for Chava Gutta Bas and Yachasia for a complete and speedy recovery with open miracles. On behalf of Menopause.org, I want to thank everyone for joining us tonight for the first event of our spring series on women's health. Tonight is the first of a two-part series on menopause, where we will focus on the medical perspective, and next week we'll focus on the halachic and emotional perspective. We have with us tonight Dr. Ezra Dori, a leading obstetrician gynecologist in New York City who has been serving the community for over 25 years. We'll be doing the Q&A presentation. We also have with us Mrs. Sarah Morozov, senior college teacher and program director at Menopause.org, who will be leading the interview. If anyone has any questions, please use the chat. It will only be seen by the hosts, and Mrs. Morozov will try her best to get to as many as she can. Okay.
Okay, hi everybody. We're just gonna move along with a series of questions, and please be patient because maybe some of the questions that you are itching to find answers to will be already answered during the original presentation. And then, as Hashem, afterwards, we will take the questions from our audience. I want to say that, as Hashem, this will be recorded, so you have to leave a little bit, and it will be posted on our podcast series or mikvah.org/audio, so you could relax and really enjoy this presentation. Again, we're going to stick to the medical topic for tonight, and next week, Hashem, we'll talk about the halacha, the hashkafa, and the emotional aspect of going through this very important stage in life. So first of all, Dr. Dori, can you please define these terms, perimenopause and menopause?
Yes, I would love to do that. But before, first of all, thank you everybody for joining us and allowing us the opportunity to go over this actually very important topic that I think is under-recognized and every woman faces essentially. Basically, no one really escapes menopause. So it's universal, and it is a very important topic that unfortunately a lot of doctors don't really spend enough time even in the office talking about it, because it's never really ever been a topic that even a lot of people are that interested in, I hate to say. Before I even get into the definition, which I will get into shortly, is there a way of unmuting Dr. Klinger and Dr. Tsurmis as well? They're also on the team, so if we can unmute them, because they'll chime in as well with additional
information. Okay, definitely. Perfect. Let me find
Wow, that's such a nice treat to have the other people here as well.
Yes, we work as a team. We're a great team. And we want to make sure that we don't skip anything or miss anything. So we're trying to give you from different angles.
Wow, okay. Fabulous.
So, you could just,
I can start in the meantime.
I just need their screen names here.
Dr. Klinger is
Klinger.
Dr. Klinger.
Okay.
Sorry, everybody. We're just, he's telling.
I'll hopefully find them. And who was the other one?
Tsurmis, Tsourmas. Nico, it could be under Niko.
Tsurmis, I see here.
Yes, so that's him.
And I'm going to hopefully Klinger here.
Okay, let's go. Bob.
I can start in the meantime. Okay, yes, so please. Basically, menopause.
Just one thing, let me know when you want me to show the slides.
Oh yeah, no worries. Yeah, so menopause basically is an event in a woman's life. I'll get to the definitions in a second, but it's an event in the woman's life where the ovaries that were producing the estrogen and progesterone to allow fertilization and all the other breast development, hair growth, etc., that was starting in the menarche, the beginning of a woman's reproductive life. This is now the end of that kind of reproductive process where the ovaries are no longer now producing the hormones that were responsible for pregnancy and everything else, which obviously makes sense because we don't want people getting pregnant when they're 85. There is a time in life where things have to happen, and this is the body's way of saying, okay, the ovaries are now going to stop producing hormones. So the average age of menopause, let's start with that definition, I would say is about 51 in the United States. So around 51 years old is about the time that women will start to experience, majority of women will be in the menopause. Perimenopause starts generally about 5 years before. Postmenopausal generally is when you have no periods for at least a year. We generally consider somebody postmenopausal. Those definitions are actually very important to us because when certain events happen in the perimenopause, for example, abnormal bleeding, it's managed in a certain way. If abnormal bleeding or bleeding happens in any sort of bleeding happens in the postmenopausal period, it's a little bit more, we take it even more seriously because we don't expect it to happen at that time. So menopause is, if you look at it this way, it's a change in one's reproductive physiology, and women undergo quite a lot of change. I can explain to you about the changes, or do you want to go through questions? Which is easier, Sarah? If you want to just let me know, should we hit the questions that you sent me, or I can go through a lot. You just have to tell me to talk or not talk.
Okay, so here's the thing, because this is going to be podcast by audio. So a lot of our audience in the future won't be seeing the slideshow.
Okay.
Therefore, whatever you show, you also have to speak about. So it's on record for the future. So whenever you want to start your slideshow, fine with me. So we talked about the ages.
Right.
First of all, can you explain what do the menstrual cycles or the periods look like during this time? Perimenopause and menopause.
Right.
What should we expect?
That's a great question. So, people are used to, 28-day cycles, bleeding 5 days, counting 7, going to mikvah, et cetera, et cetera. In the perfect world, that's how a woman's cycle is. But as many women know, a lot of times cycles are not like that. Could be due to a number of factors. Some people have conditions called polycystic ovary syndrome or PCOS, or it generally can have irregular cycles where some people bleed twice a year. Some people have periods every 3 weeks. So every woman establishes her type of cycle. What happens in the menopause is now there's a change in whatever pattern they're undergoing. And here's where the tricky part happens. I'll tell you one of the things that concern me a lot in women who are in the perimenopause. So generally people, reproductive life, 20s, 30s, even early 40s, sometimes mid 40s, having babies, getting pregnant, periods start to get different, and they get a little bit less frequent. People are also busier. So, having time for each other and intimacy, maybe even less sometimes. So cycles getting less, intimacy times getting a little bit less. So people feel like, you know what? I'm getting to the menopause. It's going to be over soon, any day now. They don't use protection. I have to tell you, I can't tell you how many times I've seen patients. Again, our business is deliver babies, healthy babies in the world. But when you're not expecting something, sometimes people have medical conditions that they are not allowed to be pregnant. So they can develop, they have high blood pressure, they have diabetes, and it can be, or they've had many C-sections. And for those patients, they're advised even not to get pregnant. And if they're not, aware of those changes that happen and what can happen, they can run into those type of problems. That's one issue. The other, to me, at least, I would say the more concerning issue is that people have abnormal cycles. And the part that's tricky is, how do we define an abnormal cycle from just irregular periods? Meaning, how do we define something that may be a pathological process, like chas v'shalom, something as bad as, God forbid, let's say endometrial cancer, to something that's just, part of the changes? It's not always very easy. So generally, women will come to my office. A lot of times they haven't been seen for a while, so they come in for an annual exam. You ask them about their periods, and they go, you know what, I have to tell you, in the last 6 months, my periods have gotten so much heavier. I've soaked through pads, then I didn't get a period for 6 months. And then again, I soaked through pads now for the last month straight. I've been feeling dizzy and lightheaded. Well, that to me is abnormal, and that warrants an evaluation. And any woman.
One second, doctor. You said a lot of information in a short amount of time. You're talking from the doctor's perspective.
Yes.
So I just want to backtrack a bit, okay? Again, I'm a little confused for the audience. There's perimenopause and menopause, and you switched the terms twice during this last few minutes.
Okay, so think of menopause as when your bleeding has stopped. Just think of it that way. So we don't expect you to bleed in menopause, period. So the perimenopause is really what we're focusing on right now.
So you mentioned one thing about having a lot of time between cycles, and then you said, and I want to just confirm that for some people that could be the opposite, very frequent cycles.
Correct. So, and that's where the tricky part comes, because you can have somebody who tells me they get periods every 3 months. every 3 weeks rather. And that's normal for them. And they still manage to get pregnant like 3 weeks, then 4 weeks, 3 weeks, 4 weeks, 5 weeks. And that can be perfectly, it's normally abnormal, if you will. You know, like it doesn't follow that 28-day cycle, but for them, that's a regular period. The concern, again, we're going to focus perimenopause, which is like about the 5 or so years before you actually go into menopause, where you no longer have your period. That's the hardest part. This is where the hormones are really decreasing. A woman is starting to feel a little more irritable. She's going to get some more hot flashes. I know we had some questions about dryness, which we're going to get into, vaginal dryness, irritability. You know, those are part of the process of going into menopause. Once you hit menopause, some of those symptoms of dryness and hot flashes can linger for a little bit. Dryness can take actually a very long time because you're now no longer providing your body with the estrogen that's needed, but we'll get into that when we get into a menopause and the osteoporosis topic, which comes right after this. But this perimenopause, meaning the 5 years before, when the cycles now change, you're going from whatever was considered normal for you to getting less. Now, in a perfect world, whatever cycles you were having, let's say they were every 3 weeks, every 4 weeks, every 5 weeks, are now getting, you know, they're a longer interval between cycles, and then they stop. That would be in the perfect world, okay? And that would be perimenopause going into menopause, and Sean, that's it, right? What happens in this, I don't find that that's a common thing that happens. What more likely happens is that people start to bleed irregularly. They either have that, as I was telling you before, very, very heavy bleeding, or they miss their cycles for 3 months when they're not used to missing it. Then it's like every 2 weeks for a little bit, and then it becomes irregular, and it becomes a bit confusing because now they don't know, is this normal? Is it not normal? Is this my period? Is it not? So how do we evaluate that? Basically, and what should we do about that? So
Okay,
the
so
first,
now we're getting into when should you consult your doctor?
correct.
I'm let's say age 45 to 50,
Yes.
or
Yeah.
I'm expecting these irregularities, shorter periods, longer periods, heavier periods. I'm kind of living with it. My 7 clean days are canceled. I'm starting again. I heard it's Meshuggah, and I'm Meshuggah, and it's fine.
Right.
When should I be worried about that Meshuggahs, so to speak?
That's a very good question. It's the main thing is when it's considered abnormal for you. And for me, I'll tell you how I usually judge it with a patient. If her bleeding is far greater than what we expect, if she tells me she's soaking through pads that she never did before, if she tells me she's had staining pretty much throughout her cycle, you know, bad processes, think of it like this, a bad process, like, you know, organic pathology, whether it's a polyp, it's a fibroid, or as hyperplasia, which is a
What's a fibroid? What's a polyp?
So we break up bleeding. We break up bleeding into organic causes, meaning there's something that's there physically, right, anatomically, to inorganic causes, hormonal. What would be an inorganic cause? A thyroid abnormality, for example. Sometimes people's thyroids start acting up. Sometimes they're on thyroid medicine and they need different medicine. Sometimes they have a metabolic condition that causes their periods to be abnormal. Believe it or not, I hate to say, but I've even diagnosed leukemias in patients, you know, in this age because they're bleeding so abnormal because it was due to you know, high blood cell count, white blood cell count, and things like that. That would be an inorganic. Organic would be something that's more, if you will, tangible. There's a fibroid, meaning a growth on the uterus. I tell people it's kind of like, think of like an orange. Like your uterus is like this perfect structure, and then you stick a little orange in there, a muscular orange. It's a deformity in the uterus that can be very benign. And you can even have large fibroids in your uterus and be completely asymptomatic, maybe a little pressure. And you can have a tiny fibroid in just the wrong spot of your uterus that can cause completely abnormal bleeding. You can have what's called an endometrial polyp. A lot of people probably heard about polyps from their doctors when they got biopsied. A polyp is simply a little growth with a little blood vessel that goes to it in the uterine cavity. A benign process, but can cause bleeding. And then you can have something called hyperplasia, where the cells are really acting up. And, you know, neoplastic or cancerous processes are really things involving, you know, new vessels, hypervascularization, you know, blood flow to an area. That's unfortunately, that's how a cancer process generally works. And so you have hyperplasia all the way up to something called endometrial cancer, or even cervical cancer if the cancer is starting from a different part of a female's reproductive tract, or even the vagina. But mainly we're talking about the uterus at this point. So we as doctors have to distinguish between organic. So if you're seeing me, you're 45 and you're saying, okay, if you're coming to me and saying, listen, my cycles are getting shorter, I feel great, I don't feel hot flashes, I'm not dry, I'm not moody, I'm not this. Again, that's the rarity. I'll be honest with you. I rarely see them. I usually have patients in this age group who have some symptom of something. Then I'm like, great, continue what you're doing, continue exercising, get your mammograms. We're going to talk about some of the other screening tests like colonoscopy. Fantastic. Now, if you're going to come to me and you're going to tell me I'm bleeding abnormally, and we're going to get to some of the other symptoms of menopause, like hot flashes in a second, but the more serious ones would be bleeding in this perimenopausal period. I'm bleeding abnormally. Again, like I said before, bleeding through my clothes and staining every day. That's going to warrant a couple of things. One of the things it warrants first is a pregnancy test, believe it or not. Because a lot of times, well, the first thing we do a pregnancy test and we find out someone's pregnant, in fact, believe it or not. I've had many shocked women come to my office and, we're about to do a biopsy. And we say, we're about to do your biopsy, but your pregnancy test is positive. We find out she's 10 weeks pregnant. And, 10 months later, we're all celebrating the birth. 9 months later, we're all celebrating the birth of a baby. So that has happened, and not too infrequently. So first thing is a pregnancy test when a person bleeds abnormally. I can't tell you how many times a patient calls me middle of the night on a Sunday, whatever, never during office hours. And I say, do you have a pregnancy test at home? They go, why? There's no way. And then they find out they're pregnant. Even sometimes people on birth control, IUDs, birth control, nothing is really foolproof. So we always have to start with a pregnancy test. Now we're going to get into a little bit of an evaluation of what we're doing. Now we're in the perimenopause, and we're talking about people who with common like irregular bleeding patterns. Other than a regular history and physical exam, because we know what medications you're on. For example, if you say, listen, I have a long history of thyroid disorders, or even if you didn't tell me you have thyroid disorders, I'm going to check anyway. But I want to know what your medical history is like. Could that affect your periods? Once I've cleared all that and I've done a pregnancy test, the next thing I want to do is an ultrasound. And I know a lot of times we speak about ultrasound, especially in the Lubavitcher community. Is it necessary? Especially when it comes to pregnancy. And these are in GYN, it's very important because it gives us some insight into what's going on in the body with a very simple device that's located in the office. A little bit uncomfortable, not terribly uncomfortable. We generally do something called a transvaginal ultrasound. So it's a probe and we insert it in the vagina and we look at the uterus. We're particularly interested in the uterine contour, and we're looking at the uterine lining. So the reason of the uterine contours, again, we spoke about before about fibroids, which are these growths on the uterus, polyps, which are a little hard to see. Generally, those are some of the things we look at. We look at the lining of the uterus, meaning if it's very, very thick as opposed to very, very thin. We like thin because thin meaning processes that are bad tend not to be thin. They tend to be really thick and make noise. So we like to see a thin lining. And then we look at the ovaries while we're looking at that as well as part of our evaluation. And then we offer you a test that I'm sure a lot of women who are on this podcast know and they've had already is something called an endometrial biopsy. We insert a little device through the cervix. It's an office procedure, does not require anesthesia. It is uncomfortable because it causes cramps. And we aspirate cells from the uterine lining. That is to be distinguished from a pap smear. So remember, when you're a young woman, 21 and older is when we start doing pap smears in this country. We're looking for cervical abnormalities and cervical dysplasia. So we'll have already done a pap smear as well, because we're interested also in the cervix. We don't stop checking pap smears, but now we're going further and inserting a little device through the cervix into these. Now, a lot of times we get is it Shyla? Should I ask? Because sometimes by the time they see me, they're already starting to get clean and they want to know they can count. And it's a Shyla. We are going in the uterus. We are taking cells from the uterus. So it is a Shyla. So I always tell people, listen, you're going to become unclean from this procedure. So we've done our pregnancy test. We said it's negative. We've done our ultrasound and physical exam. And now we proceed to a biopsy. Biopsy gives us a lot of information. Back 20, 30 years ago, those women were all brought in for DNCs under anesthesia, where a DNC means dilation and curettage. We're opening the cervix and scraping. A much more invasive procedure under anesthesia that's not as necessary for this particular situation. That began the evaluation of the abnormal bleeding in perimenopause. So basically, so it sounds like a lot, but believe it or not, it's not. In the office, it's all of 20 minutes, 15 minutes. And we also do blood tests. We check a blood count to see anemic and things like that, and thyroid. As I told you before, we find a lot of people with thyroid disorders. we put the whole picture together, and it then becomes easier to decide, how am I going to treat someone with abnormal bleeding? We worry about treating with hormones, birth control pills, progesterone. You'll hear a lot of these natural remedies out there because we're afraid of what they're going to do to the uterine lining and what they're potentially going to do to one's breasts. We worry about breast cancer, giving people too much estrogen. So we have to be careful on the treatments, but we need the information before we can recommend treatment.
So I want to ask you another question. I'm hearing all this, there's such a big movement out there, you're going through menopause, take these herbs and take those herbs and acupuncture and this and that. Are you trying to say that before you go to all that places, please first make sure that your body is well?
Yes, always.
Because first, make sure there's no polyp, fibroids, anything physical that has to be treated.
Correct.
Because we don't want to miss something, chas v'shalom.
Correct.
That actually is a very unhealthy situation. If we wait later, it's actually
that's right,
more complicated or more.
Right. So, for example, polyps are very easy. A polyp is, I usually actually don't treat them right away. But for example, if I see somebody who's 45, I've done my full evaluation, I see an endometrial polyp, it's a benign process. I tell them, listen, let's see how your next couple of months to years go. If this was it, maybe that's it. But if they continue to have a problem, we do a procedure in the hospital called a DNC that we spoke about before, and a hysteroscopy. You might have heard that word, where we actually have a little camera that we can stick inside while we're doing the procedure to actually look to see any irregularities. So that's something we'll do for a polyp. A fibroid, fibroids are tough in a 45-year-old because we don't like to take just fibroids out. At that point, we're either gonna give you some medicine to shrink it. We may go as aggressive, depending on how bad a person's bleeding. We may go as aggressive as a hysterectomy. It all depends on the symptomatology. There's something also called uterine artery embolization, where we block the blood supply to the uterus. There are many, many treatment modalities. So that's something you'll individualize with your own doctor once they give you this idea of what it could be. My job here right now is to tell you, these are one of the things that your doctor is actually looking for as a cause of your bleeding. Majority of the time, I'll tell you what vast majority.
Yeah, I want to hear about the majority of the time.
Majority, I'm
really fainting on all this.
No, your majority of the time,
like,
you're going to come into the doctor's office. I'm going to do that evaluation. I'm going to get your history. We're going to do your pregnancy test. We're going to do your ultrasound. We're going to do your biopsy, and we're going to do some blood tests. After we do all that, majority of the time, we find that you have benign tissue on the biopsy, your pap smear is normal, your thyroids and CBC or blood count is normal, and we're just going to tell you to keep an eye on it. That's the majority of the time. So not to be scared, everyone. I mean, the majority of the time, everything's fine. But for the minority that it's not fine, that's who we're looking for. And we're trying to pick those people out that we can provide that further treatment. And the reason we're going through all the other mishigas is to find out who really needs us to take their step a little further.
Great. I want to move on now. We talked about spotting and bleeding and all that uncomfortable stuff. Can you now tell us some of the other symptoms that are not, they're just that are a bit uncomfortable?
Yes.
And maybe they're like quality of life is compromised, but not like they're not a medical risk.
So
and how would that be? How would we take care of that to make it easier?
So that's a tough one because it's not such an easy treatment. Some of it is just irritability. People, all of a sudden, they come to my office. They're like, I don't know why, I'm just crying. I go home. I have a little insomnia. I start crying. So it's emotional changes. And I'm going to get to that one in a second because I want to talk a little bit more about that. Hot flashes, that runs the gamut from I've never had a single hot flash to, if you don't give me my estrogen pills, I feel like I'm going to commit suicide. Like I've had people literally, they come to my office like I'm giving them an addictive drug. That's how bad they need it for their hot flashes. So it runs the gamut from nothing to so severe, and then many people in between. And then vaginal dryness and irritation. That's normal. Again, your estrogen that you're lacking from the ovaries producing that is expected to be. The vagina is going to be dry, and intimacy is uncomfortable. And just in general, people get more urinary tract infections. It's just uncomfortable. So let's get into that one. That one's an easy one. That one you can either apply localized estrogens. We have creams that we tell people to put on for sometimes 2 weeks on, 2 weeks off. Certain non-glycerin based lubricants like the Astroglide, KY jelly, we tell people to put those on and they generally feel better. If you have a combination of some hot flashes and some dryness and even a little bit of irritability, either I'll put a person on a low dose birth control pill if they're still young in the mid 40s, or I'll go right to something called hormone replacement therapy if they're a little bit older. The big thing with hormone, when I was a medical student, almost every woman at the age of 48 to 50 got hormone replacement therapy. It was like, there was almost no question. You got it, because we knew you were going to get hot flashes. Then they did a study on a bunch of nurses in Boston, and they said, you know what? There was a higher incidence of breast cancer. We can't recommend this anymore. So now everybody got so afraid of it. So now what we do is we still prescribe it, not because we want to give somebody breast cancer. We obviously, medicine is all risk and benefit. What we do is we pick the lowest dose that we really, really need, and we prescribe that to the patient. And I tell you, it works very, very well. We tell them to get their mammograms, right? So you always want to make sure your breasts are fine. We tell them to do breast self-exams, because we are concerned that we're giving you, again, exogenous hormones. So you're taking something that we're giving you that can affect something else. So people don't understand, when you take a Tylenol, it gets processed through the liver, and it goes to different parts to take care of your headache, but it does other things to other parts of your body. Every medicine does that. So does hormone replacement therapy. So life is all about risks and benefits. So what happens here, if I say to somebody, here's a little bit of hormone replacement therapy, you're going to feel a lot better. Then they go and they read the package, and then they go, oh my God, doctor, you want to give me cancer? And I'm like, I'm not giving you cancer. Okay. And like anything in life, it's all risk and benefit. I'll tell you, this is what I always tell people. My office in Borough Park, crossing New Utrecht is far more dangerous for me than most other things. You know what I'm saying? Crossing the street in most of our neighborhoods, I find far more dangerous than taking my pills. You know what I'm saying? So life is all about risks and benefits. You have to look at how much benefit am I really getting for the small risk that I'm taking, that I'm being monitored for. The one other thing I wanted to touch on, tell me if I talk too much, interrupt me certainly, but the one other thing is the emotional changes that people undergo. And that's a tough,
actually was the next thing.
yeah, that's a very, very tough one. So I always tell people like this. Number one, this is a tough time in people's lives. Think of what happens when people are in their 40s. You got married when you're 18 to 22. Okay. You had your kids then. These
25 to
20, and nowadays a little bit later, I was just trying to be generous with the 18. So basically, your kids are now, in their 20s and teens, and then you have some young ones. A lot going on at home. Okay, this one's getting married, this one's having a baby, but this one I got to go to the PTA meeting. You got a lot going on in life. Plus, some people work, and it's hard. People get sick, also parents, and a lot of stuff. So you have the exogenous factors that you got to deal with. And also and the hormonal factor. So you put the two together. It's almost like when I tell my patients when they're postpartum, I go, the first couple of weeks of postpartum is like a short period of manic depression. Yeah, 1 second you're going to be smiling, the next second you'll be crying. It's all part of the course. It's part of hormonal change. Same thing that happens here. So what can one do? So there again are pharmacological options and non-pharmacological options. So what would be a non-medicine option? I always tell people, first thing to do is please decrease caffeine and decrease your sugar intake, eat healthier, and exercise. I know that sounds great. We should all be doing that, but that really does work, especially for people who are having these things. I can't tell you how many times I've had patients, the new coffee shops that open up and they have these fancy lattes with a million things of caffeine in them, dosage of caffeine. They come in there wired. They don't even know what's going on, and so the sugar and the caffeine is just never a great combo. So I tell them first, let's try some dietary changes. And then let's look at your life. Is everything okay at home? Listen, we all know there are some things that are not so okay at home. Let's see, obviously we can't fix a person's, financial situation, this situation, that can't fix everything, but we have to look at it, take a step back and say, what's important in life? Let me kind of fix myself a little bit, like get myself together so I can handle this overwhelming period of my life. And then if we looked at we did the dietary changes and we did that, then sometimes we actually prescribe either hormones or we even prescribe some antidepressants, like a little Zoloft, which is not so bad. You take it for a little bit of time to just kind of get you through this period and make you feel better, because we need somebody. Sleeping and eating, to me, are my biggest guidelines on how a person's doing. If you're sleeping well and you're eating properly, you're pretty okay. If you're to call me and tell me I cannot sleep, I cannot do this, I'm not eating right, then I know you got a little bit of a problem, and you need to be treated a little more than just diet and exercise.
Wow. I want to ask you a question.
Yes.
You're a male talking to female.
Yeah, good question.
Okay. What about male menopause? Like, is that in the mix?
So, what? I think, what they always say, when you're like really next to someone, you kind of take on their type of symptoms. I think men, listen, men have to be very supportive. And here's the problem. I'm an OBGYN, so obviously I understand what women go through. And I'm married to, my wife, and I understand so I get it. But you got people that listen, they're not in the medical field at all. And all of a sudden their wives are complaining, oh my God, I can't sleep. I have hot flash. And they're looking and they're too busy with whatever. They're not taking this stuff seriously. So I think it creates a little bit of friction amongst people. So this is a time that sometimes it's good for the husband to come in for the office visit, to hear like how bad this patient is suffering, and he has to be a part of it, like to help her. Do men themselves go through menopause? Not really. Men have a whole different physiology. So, that's why men can still, have, produce sperm to have babies even later. You know what I mean? So their hormonal and anatomical situation is far different. So they don't actually undergo that. The only time you see men undergoing certainly it's, again, the life stuff that happens that stresses people out. But there is no real, if you will, male menopause, I think, but the male partner needs to really understand what a woman's going through. Some are very supportive and just some are really not. And I think that the non-supportive ones are really the ones that are, I guess, harming, the rehabilitation, the treatment of the perimenopausal period in their wives.
So I want to ask you a question. I know you're
Yeah.
a medical doctor and you're talking about what the medical establishment has to offer.
Yes.
But in all honesty, and I know if you're in Borough Park and in Williamsburg, I know you know this phenomenon of like vitamins and herbs. And
Yeah.
So can you be a bit honest here? I'm sure
Yeah,
there
yeah,
are some,
of course.
even you as a medical doctor, and we do have another lecture from somebody who, Sarhana Silverstein with her natural medicine and what she has to offer. Mikva.org, we did interview her, and you can all watch her podcast to see the alternate options. But I want to hear from the medical perspective.
Yes.
Are there some that you've seen actually do help ease the symptoms? Again, after we rule out, there's no fibroids.
Yes.
There's nothing dangerous going on in my body, but I want to ease the symptoms of either the bleeding or the hot flashes or the dryness or the moodiness. Have you seen from all your experience in the for all these decades, things that really help that can supplement what you're trying to do?
So I'll tell you, you know what? If you tell me acupuncture, or you tell me, some sort of massage therapy, or, psychotherapy, meaning that, people have psychologists that they speak to or counselors that they speak to. Yes, those I find really are helpful. The problem with vitamins is people believe that they're very natural. So how can a natural substance be so bad? Because it's like everything in life. Too much of anything and anything unnecessary can definitely harm somebody. I'll give you a perfect example. They found many years ago vitamin A, and they found that too much vitamin A actually harms fetuses, but vitamin A is found naturally in foods and it's a natural product. So too much of anything to an extreme is always. So when someone walks into my office with 15 vitamins and thinks that they're going to be superwoman, it doesn't really always pan out. And again, these are medicines that are not regulated, most of them. So we don't really know. And it's a high dose of something that may be affecting other things in your body. So I'm not anti-vitamins and I'm not anti this and I'm not anti anything. I just think that you have to look at it in moderation. And if you're trying something, my rule is if you're trying something for 30 days and it hasn't really helped you, it's probably not going to help you. So don't buy any more of it, and we have to think of an alternative plan.
But you don't have anything that is for sure helpful.
There's nothing in life that, no. So some people will say black cohosh tea, for example. Some of the stuff that we use, in women in labor, even, red raspberry leaf tea, some people believe primrose oil, evening primrose. I mean, those are all throughout the years. Those would be some of the remedies that people would always talk about. I certainly have no problem with people trying them. And I think that if it works for you, Baruch Hashem, continue it, use it. And that's good for you. But if in 30 days you find that, hey, this stuff's not working, let's move on to something a little different.
So I just want to go back to something you said earlier, which is it's common to have heavy bleeding. Can you define what you mean? What kind of heavy bleeding really warrants visit to a doctor? Like more specific.
Yes.
It soaks through your clothes, like once a day, once a night, once an hour. Just
I always
specific.
It's a hard thing to be specific because it's very individualized. I always tell people, compared to your normal, give me an idea of what your normal is like and tell me. So if you've never soaked through pads and through your clothes, that's really abnormal. If it happens that, like you got an IUD and you're bleeding heavy and you notice that for example, you bled like so-and-so for the last couple of years. Now you got an IUD and the bleeding is heavier. Okay, so that's expected. So it's really what's abnormal to you as an individual. It's a tough one. Let me tell you, it's very hard, but I will tell you as a doctor, we are far more comfortable, doing a little biopsy, even when there's a little, like, is it really abnormal? Is it not? So in order to solve that, I sleep better at night when I know that I have a negative biopsy. Also, why? Because sometimes I get that, and all my partners that are on now know, are on the line here. They all remember that they all get the phone calls that I get 4 o'clock on a Friday afternoon. Now I'm really bleeding heavily. Now what do I do? So if I have a negative biopsy on someone, I can say, I've already done your evaluation. It's a negative biopsy. You're fine. Get ready, for Shabbos and stop worrying about this. You know what I mean? Like, so it gives us the opportunity to tell you, you've been evaluated for it. And really, it's almost shameful in this day and age to miss, an endometrial cancer in a young woman just by simple biopsy. So to me, it's a little discomfort. Don't get me wrong. It does cause pain, nothing excruciating. Cramps, like a really bad menstrual cramp for the time that we do it. And I tell people if they can to take some Tylenol or Motrin rather before coming for the procedure. And it gives us a ton of information,
Wow. Now you mentioned way back when how many women are surprised that they got pregnant. They thought,
Yes.
they're having like, oh, I'm not getting pregnant anyways. I'm 40, whatever.
Yes.
And my periods are less likely
Yes.
to come. And all of a sudden they find themselves pregnant. Like, up until what age?
That is such a good question. I have to tell you, until you're really menopausal, I get that question all the time. And I have people that are deathly afraid of getting pregnant. They're on birth control and they're not stopping it until you tell them, listen, you're not getting pregnant. And they'll take the medicine until they're 80. I'm telling you, they'll take birth control until they're 80, until I literally have to beg them to stop. It's a tough one. I like to put them on until they're about 50. And then what I do is I take you off the birth control. If it's on pill, I take you off the birth control pill, because then I can check your hormone levels a month later, and I check something called an FSH level. So it's just kind of tell me your ovarian reserve, and if the ovaries look like they're not so functional, meaning that we're looking for a number of above 40, let's say, then I'm more reassured that it is highly unlikely that you're going to get pregnant. And if you have an IUD or you have something, you're not taking something hormonal, I just check your FSH at that time. So there is a hormonal test that we do look at. And I haven't had a patient pregnant after checking all that. And saying, okay, your FSH was 55 and then they come back pregnant. That's never happened yet.
And what if they have a very low FSH?
So then the other question is, and let's say you have a low FSH and you're 53 and you're still on the birth control pill. Listen, I'm not so excited about that, because I don't really, the whole idea of the birth control pill is to, we don't want you to give you exogenous hormones that can affect your breasts and things like that. I start to then transition. I start to talk to them about some other forms of birth control. I really don't like birth control pills at that age. I do have some people on it. They really like it. They feel better on it. They can control their periods and things like that. So I do that. Again, this becomes, a shared risk with your provider. You need to know what some of the risks are in terms of, God forbid, developing some problems with the breast. And if you're willing to undergo those risks, and I don't think that they're terrible risks, because otherwise, if they were terrible risks, I would tell you definitely don't do it. I just want you to be aware that, look, you are taking something that's kind of not really what it's intended for. But I see why you're taking it, because you don't want to get pregnant at 53, and and also because you're feeling better, because you're controlling your periods and things like that. Because when I take people off of these medications and they bleed abnormally, I feel like it's the worst thing for them at that time, because now they're subjected to, again, the biopsies and the evaluations. And 53, people have no time for that. They don't have time for that in general, so let alone at that, you know what I mean? So at that age.
Wow. What's the oldest, I'm curious, in your office, what's the oldest age a woman came in pregnant?
Pregnant. We had one that was turning 49 when she had her last baby. She was actually very surprised. She was new to me, and she was quite surprised because she came in and I think she had irregular periods, and we told her she was pregnant. I think she thought we were like we came from Mars, like are you kidding me? Like, I know I'm not pregnant. I'm coming to you. You guys don't even, and you're supposed to be OB-GYNs. And we're like, you're pregnant, and she couldn't believe it. And she ended up, she did great, but she was quite surprised.
So that's pregnant with a live baby. I'm talking about pregnant and, most often it's miscarriage anyways.
So that happens. That happens again. The later one gets pregnant, the more you run a risk of a chromosomal problem. So that's another concern for a lot of people. The a baby with chromosomal problems and miscarriages. But the rate of miscarriage in general is 15 to 20% with every pregnancy. I would say it's slightly higher when you're older. But listen, Baruch Hashem, we see women in their 40s who are fine getting pregnant, 42, 43, 44. That's a common age. In my practice, when I was just joining, I would say 45 was even not uncommon and 46 wasn't so not uncommon. Now I don't see those ages anymore really interested in getting pregnant.
But medically, it's
Medically, it's
it
fine to,
happens.
again, assuming you have no cardiac issue, you have no high blood pressure, how many C-sections, if you've had several C-sections, we worry about what could be with the placenta and things like that. It can become dangerous pregnancies. Assuming you don't have those problems and everything was, let's say you have, all natural deliveries and everything else fine. Yeah, there's no other than the risk more of a slightly high risk of a chromosomal problem. There generally isn't, we still are watching you for preeclampsia. Those are conditions of pregnancy that happen a little bit more often. Diabetes of pregnancy can happen a little bit more often. So you're always being watched for that.
So I have two more things I want to ask.
Yes.
One is, did Dr. Klinger or the other doctor on want
Yes.
to add something or just introduce themselves?
Yes.
And while they're getting themselves together, you had mentioned about osteoporosis
Yes.
and colonoscopy.
Yes.
I assume that most people, I hope everybody on this who's listening to this are doing their yearly physical exams, and probably their GP is taking care of the colonoscopy and osteoporosis.
Yes.
Do you overlap? How does it work?
So that's a very
manager of the health over here.
I have to tell you, the best opportunity is this opportunity to talk to you about screening tests, especially colonoscopies, because there is an uptick in colon cancers, especially amongst the young. And the recommendations had always been age 50. Now it's 45. And the problem is colonoscopy is it's like, going to the dentist. It's like, the thing that people really don't want, going to the gynecologist, going to listen, the unpleasant things we all try to avoid. I get it. But it can be life-saving. It is an important screening tool. There are some excellent gastroenterologists that are around town. I would caution people who do their colonoscopies to please read about a diet before your colonoscopy, avoid certain foods and all that a couple of days already, 3-4 days before. Because remember, colonoscopy is a test that, they have to put in a scope and look inside the colon. And the best prep is going to be the best diagnosis you're going to get, to make the diagnosis. So of anything, polyps and things like that. Polyps are things that can be removed during colonoscopy. So 45 years old. And then the interval to rescreen depends on family history and depends on what they find at that colonoscopy. So if you're completely clean and you've had no other family history, you probably are going to be told 5 to 10 years. Now about 5 years, I would say. I don't think they're doing 10 years anymore. But generally, don't be surprised with 3 years to come back for colonoscopy. Mammograms, I just also want to add, is a bit of a sore point because especially if it's your first mammogram, it's not uncommon that they tell you to come back and I get a frantic phone call like, oh my God, they told me to come back to have breast cancer. No, they don't. Generally in your 40s, breasts tend to be a little dense. So when you get your first mammogram, remember mammogram, they're giving a squish here, a squish there. It's not really a great look at a breast. So sometimes they have to do something called magnification views where they need to magnify a certain section because they can't really tell, or they make you have to come back in 6 months. Don't be surprised by those. Those are very common. In our world, it's a very common thing. If they see something that's bad, we usually act on that rather quickly. We don't tell you come back in 6 months for something that's bad. An appointment's already made, biopsies are scheduled and things like that. So mammograms, colonoscopies, very, very important for women. I'll let Dr. Klinger, Dr. Shermas come on as well, but we should really focus a little bit also about osteoporosis and some of the preventions of osteoporosis and fractures. That now we're going from the perimenopause, which we kind of spoke about a lot, and now we're going to menopause and postmenopause and what is to be expected in that phase. So once this whole bleeding stuff is done.
1 second,
Yeah.
Dr. Dori, can we just
Yeah.
backtrack one more thing?
Yeah.
Again, as a woman who's managing my health, is there some overlap between, doesn't the GP take care of the, what did you call it, the colonoscopies?
Yeah, that's fine. Either us or the
do you, is it either or both, or
so when a patient comes to me, I'm asking her generally, have you done your colonoscopy? And many of them will have said yes or no, or either yes or no. But if they say yes, a lot of times their GP will have done that. So if you're going to, listen, you have good doctors in your community, Dr. Rosen's office. I mean, they know already what to do. So those patients almost all have had a colonoscopy on his recommendations or his partner's recommendations. So it's nice, it's good. So they've already known about it. So listen, it's my job, it's Dr. Rosen's job, it's all the doctors' jobs to say. So if you heard it from them and you haven't done it, you're going to hear it from me, and hopefully you'll do it. You know what I'm saying? So it's our job to work as a team, because Dr. Rosen's not going to call me and say, oh, by the way, I had Ms. Marusov do a colonoscopy. It's not going to happen that way. Until you see me, I'm going to ask you, have you had a colonoscopy? You'll say yes, no, and then we take it from there. So there is a little bit of an overlap. But our job is to make sure to educate you on doing it.
Okay, so now we go, that was all perimenopause. Now women for 1 year, you had no periods, mazel tov.
Yeah.
Now, doesn't mean you're never bleeding again. When do you get nervous about bleeding? When do you visit a doctor?
So Dr. Klinger, if you're on, it's a very good topic to talk about post-menopausal bleeding, which is handled even more differently, because it's a little bit more, if you will, I hate to use the word ominous because it scares people, but it is a little bit more ominous when we don't expect something and all of a sudden we see it, but it doesn't always mean something bad, just so you know. Majority of the time, it's actually not bad. Dr. Klinger, are you on? Or Dr. Sermis? This way, it's a good opportunity for you guys to meet them as well. I'm sure you've heard me talk a lot. But if they're not on yet, I can start to continue to talk about that as well. But generally, let's see when they get on. But let me see. Hold on.
Yeah. Dr. Klinger is unmuting himself. I see.
Oh, good.
Let's see you, doctor.
No, they said they stopped the video. So can we get his video and audio back on?
He's right here.
Oh,
you stopped my video.
Oh, there we go. Okay, you're on.
No, my audio. Anyway, my video was stopped.
Yeah. Are you there?
I'm here.
Oh, good. So we're up to postmenopausal bleeding and the evaluation of So a woman has not had her period for a year. We said she's postmenopausal. And now how do we manage postmenopausal bleeding?
Okay.
You'd have to start your video again yourself. You're pinned.
No, it says you can't start your video because the host has stopped it. So it's okay. I can talk without
It's
video.
strange.
Look better in the picture anyway.
You can make co-host.
No problem. Anyway, so once, it sort of overlaps, because any abnormal bleeding pattern, as Dr. Dori mentioned, in the perimenopause, and a good way to say perimenopausal is everything that's not menopause is perimenopause, right? Because peri means next to. So if we're not menopausal yet, we're in the perimenopausal stage. But in any case, I mean, the first thing is when someone has already not had bleeding for a while and is officially menopausal, any bleeding should prompt an evaluation. Not all bleeding is bad. There could be bleeding from external sources. Remember, the vagina is drier during the menopause. There could be external bleeding from irritation to the vulvar skin and the surrounding areas. There could be bleeding, from the urinary tract and stuff like that. But we must exclude bleeding from the uterus, because that could potentially be a serious condition. And the way one goes about, at least the first step, would be to do an office endometrial sampling, what Dr. Dori mentioned before. It's a very easy procedure. I just want to add that it's not necessarily makes you unclean. I know from certain rebbeim that I've dealt with, the size and width of the catheter that is inserted into the endometrial lining has implications as to what the halachic status is of the woman. So an endometrial biopsy curette, what's used in the office, is something that's less than 2 millimeters in width. And, that's what I would, I've had patients ask me, what was used. I'll tell them what was used, and they can discuss that with their Rav as they wish. But, it's an easy office procedure to do. In the old days, every woman in this situation would need a full D&C in the hospital under anesthesia and whatever. And we can really almost do as good a job with doing an office endometrial sampling. So that's what happens first. We would probably also do an ultrasound as well, and certainly do some blood work, and then put it all together. And then depending on what we find, we may need to either move to a fuller D&C, which is because when we do the sampling, you can imagine it's a small little catheter. It's much smaller than the entire uterine cavity. It's not. It doesn't always sample the entire uterine cavity. So depending on what the results say when we get the reports back we might need a more complete sample. So sometimes that does require a D&C in the hospital.
So that was for the postmenopausal bleeding. There are other issues again with the menopause. Remember, some of the things we spoke about earlier with the irritability still persists, the dryness still persists, and
Right.
so
I mean, there was one thing that I wanted to mention before. You said about natural methods and things like that. So I'll tell you, a lot of times, there are some that that are have been used historically for a long period of time. So for like mood issues and things like that, a lot of people use valerian root. My parents even use it. Alayhim shalom. It's known to have certain sedative and anxiolytic capacities. So valerian root. A lot of the soy-based products, things with like phytoestrogens and things like that, can be helpful for hot flashes. Like Dr. Dori said, when I was training, certainly, we trained around the same time. I mean, we were giving out, hormone replacement therapy like water. And yes, there was one study, increased breast cancer, then not increased breast cancer, then increased heart disease, then not increased heart disease. But I still think there's room for hormone replacement therapy. I don't think that it increases your risks for breast cancer that severely. Unfortunately, the risk in Ashkenazi Jewish women of breast cancer is extremely high in and of itself. That's a whole other issue. But besides that, actually, some of the second line treatment now for hot flashes, and this you may not to say whatever, but you may accomplish two things: is using Paxil. Paxil is one of the the SSRIs. It was used originally to treat depression, but in low doses, actually a single dose of 7.5 milligrams, which is actually lower than the dose you usually use for depression, has been shown to be beneficial for hot flashes in the management of hot flashes in pregnancy. I mean, in menopause, sorry. And then there are some older medications that we don't use that much anymore, that were like, one of the drugs that was used for one of the first line treatments for high blood pressure, actually called
clonidine.
Not what?
Clonidine.
Clonidine, not clonopine.
Yes, correct.
But it was used for high blood pressure, is a centrally acting agent, and has also been shown to be helpful with the management of hot flashes, or what they call vasomotor symptoms.
This is like a discussion with the doctor on the some of your options, and if this is not working, then we should try this, and if that's not working, we should try that. We generally get people happy with whatever we give them. I mean, again, hormone replacement therapy or some of the medications that we recommend generally ease a lot of the burden.
Okay, so before I just wanted to talk a little bit about osteoporosis in a moment, but I do want to mention to the audience, Nechama, do you want to mention about other podcasts we have already about menopause? I don't know if you're on, Nechama.
Yep. I'm on.
So what are the other podcasts that we already have available on this topic of menopause, mikvah.org, or those three that we talked about?
Yeah, so I'm gonna post a link in the chat to these three classes. Of course, we encourage you to browse and listen on mikvah.org on all our classes that are available, but we wanted to specifically mention this is Rivki Boyarsky's class, which discusses the interplay of science and halacha as you prepare for entering perimenopause and menopause. We also wanted to mention this is Dr. Heather Applebaum's class, which guides mothers in supporting their growing daughters through physical changes of puberty. And the third is, which we mentioned before, this is Sarah Chana Silverstein's class, A Natural Approach to Understanding and Improving the Nidja Cycle, How to Integrate Herbs and Alternative Treatments with Conventional Medicine to Regulate the Cycle, Control Staining, and Improve Overall Women's Health. And I will post links to these classes on the chat.
Okay, and as we let Dr. Dori and Dr. Klinger, maybe the third doctor wants to come on to wrap up about osteoporosis and whatever other health issues, if you have any questions, can you please post them now to the whoever you want to post them to, either to Dr. Klinger directly if you see them, or Dr. Dori, or to Sir Morozov. And we will address them now. And if we have no questions, we'll let the doctors wrap it all up. And yeah, very, very informative.
Thank you.
And Brina, they're next week, Tuesday, not Wednesday. So note that change of time and change of date. We will have Mrs. Esther Pekarski and Ms. Kai Klein addressing the halachic and the hashkafic and emotional aspect of a woman going through perimenopause, menopause. So the halachic and hashkafic questions and emotional, please hold for next week. Okay. So in the meantime, Dr. Dori or Klinger or the third doctor about osteoporosis, let's hear.
So I'll just one of the things that are near and dear to me also, I do give osteoporosis lectures. Rather than bother you with the slides, osteoporosis is basically weakening of the bones. And it's a process that happens. And again, for some people, it happens far faster than others. Thin Caucasian women tend to have the highest incidence of osteoporosis, dietary changes, the sunlight situation. Remember, people are generally covered in our communities. We're not living in Florida, so we're not really exposed to the vitamin D that we all should be. And we're not all taking enough calcium in our diets. So those are some things that do prevent osteoporosis. Weight-bearing exercises are also, very, very helpful. Getting a good diet, basically, and exercise is always good. What's the problem with osteoporosis is the fractures, and that's what we're trying to prevent, because it's like, you have like a building that you don't want to ruin that foundation, so it starts to crumble, and that can happen as we see the disastrous consequences of what happens when bad things happen, like something as terrible as Surfside, things that just all of a sudden fall apart. Fractures are extremely common. The bones are brittle. I am going to caution the audience that are listening that are in your 60s, 70s, and 80s. I don't know if we have that age group right now listening, but those in the 40s and 50s are going to, God willing, get to those ages in a few years. Watching something as simple as avoiding falls. I know this sounds so basic. I'm telling grown women to watch for them from falling. It is so basic. It happens all the time. I can't tell you how many times, grandkids are over, the toys are on the floor, a little ball's on the floor, you walk on it, you fall, you break your hip. Now, when you break your hip, you're buying yourself a nice trip to the emergency room, which is lovely. And you're buying yourself a little operation, lovely. Nobody needs that. So what we want to do is we want to avoid getting to osteoporosis. Again, there are risk factors if there's a strong family history, if you're very thin, again, Caucasian, those are the risk factors. But again, calcium, weight-bearing exercises, vitamin D. There are tests to see if one has osteoporosis. Some doctors order them in the 50s. Really, they're not supposed to be ordered until 65, unless you're on medication. So if you're on steroids, certain thyroid medications, they do them earlier. If you have any other reason to do them earlier, it's called a DEXA, D-E-X-A scan, where we send it to a radiologist's office, like you do a chest x-ray or a sono, and they do a DEXA scan, and they give us a score to give us the risk factor for osteoporosis, and we see how brittle your bones are. And there are treatments beyond calcium. There are actually many more stronger treatments that we do give people. But falls, hip fractures, I know that it sounds, again, so basic. It's like when I like to remind people, check your smoke detectors, please. I know, again, sounds basic, right? Why is this doctor keep telling me about smoke detectors? Of course I'm checking, but you'll be surprised at how many people forgot to check the batteries in the smoke detector. So by the way, after this conference, maybe tonight, you'll check your batteries in your smoke detectors. But things like that are just something simple to know, so that we don't see people in the emergency room for something as simple as, slipping on something and falling on something. And again, osteoporosis is a real fact. Our bones get brittle with age, and your fracture risk becomes that much greater. That's why you see when little kids walk and they get a little, they break out an arm and then they walk around with a little cast. All of a sudden they're fine and they're playing again. But we are not like that when we get older. So the healing process is much, much more complicated. So please, diet, exercise, and good lighting in the house, good shoes, especially when it's raining, icy, snowy. I know, basic, but it'll save you loads of trouble. I promise you that everybody who's listening now knows somebody who has some fracture, whether it's a vertebral fracture, a hip fracture, and when they go back and see how they got it, they'll see that a lot of times it was because of something that was silly, like tripping over the grandkids' toys or someone's backpack and things like that. So I'd love to take questions. Oh, I cannot hear you, Sarah.
Okay, I don't
Yes.
have any questions directed to me, so check your chat if you have questions
Yes.
directed to you. And if not, I would say this was such a clear, informative session. There left no room for questions.
Well, actually, I think there was a problem with posting on the chat, which is open now. If anyone wants to quickly post a question, and the hosts will see it. We'll wait a minute or two, then we will close.
I'm just curious. I mean, you did mention some of the changes in medication that's prescribed years ago versus now. Do you see different patterns in menopause? I mean, we have a different lifestyle. I don't know if it's the air technology, sunlight, hormones, who knows what. Do you see like differences in patterns of like how old, like are women reaching menopause at later ages, younger ages, or it's the same?
I think in my experience, it's the same. Dr. Klinger, what do you think? I mean, to me, I think it's the same.
Pretty much the same. I mean, the average age is still 52.
51, 52, yeah.
The best indicator, though, the best indicator for a woman of impending menopause is her mother and her sisters, if has older sisters.
Okay, so here we have a few questions. Question number one, if a girl gets her period early, will she menopause early as well?
Sometimes yes, sometimes no. Not always a guarantee.
Is it normal that I'm 52 and a half and I'm nowhere near menopause?
Normal. It goes, we say average meaning 50% below, you know what I'm saying? So average doesn't mean by if you're 52 that, oh my God, I passed 51 and or, you know what I mean? So it's average. So it's not uncommon.
Okay. What is there an age to get an endometrial biopsy if you have no symptoms? Is this like part of a routine checkup? Or
Excellent question. So I will tell you, we generally, as a rule, use the age of 35. So once a woman is 35 or older.
No, but without it, she was asking without abnormal
symptoms.
bleeding.
Well, without abnormal bleeding, we don't do biopsies. No, only for abnormal bleeding. But 35 is when we start to really get concerned about a bleeding irregularity.
Okay, so no symptoms, no biopsy.
No symptoms, no biopsy.
Okay, I'm 52. I'm as regular as ever. When can I expect to enter menopause? I guess we got a lot of women, you know.
Yeah. Weiß nicht, as we say, we don't know. Well, it'll happen, you know.
But could these women still get pregnant?
So if you're getting regular periods, listen, if you're still getting periods, I always tell people, if you're still getting regular periods, you still can get pregnant, period. You know,
Age 52, at age 52.
Yes. And didn't you know about it? I think there was a patient in Borough Park that was in the community. I don't know. I heard it through the grapevine. She was, I think, 54 just now, not so long ago, that got pregnant, and patients of mine verified it. That's all I can tell you.
Okay, so this is just a clarification because someone asked, can you be pregnant and be in menopause at the same time? And no, because either your ovaries are producing babies or they are not.
Unless you're like Hashem, it's like a chemo and the ovary shut down and you got IVF, like a certain pregnant. It's essentially no. You know what I mean? It was not a physiologic process to be in menopause and pregnant.
Okay.
You know, if you're in menopause, you're not getting pregnant.
How else would chemo affect menopause?
So nowadays, there's a good question. A lot of it has to, it's a discussion with the doctor. Certain medications now don't affect anything, and people actually get pregnant. We used to tell everybody getting chemo to save their eggs and things like that, and some doctors will still recommend that. For especially, unfortunately, a lot of young women get lymphomas and Hodgkin's, non-Hodgkin's, etc., and they get treated. But nowadays, not many doctors are pushing saving eggs. And they get pregnant, and it shouldn't really cause premature menopause. Premature menopause could be a genetic problem. The medications can cause it, but generally a genetic problem. It's a rarity. We don't see a lot of premature menopause.
You don't see a lot of premature menopause?
No. The few that I've had, I had one recently that was quite young. I was quite surprised. We didn't really even find anything. It's just all of a sudden, it was just a very unusual thing. But there is a workup. We generally want to make sure their chromosomes are normal. Like I said, it could be a chromosomal problem. It could be a medication problem. It's very rare. Most people are going to experience it in their 40 to 50 range age group.
age group. Now, if somebody had FSH levels that are high, can they
Yeah.
go back down again? Like,
Yes,
is
they
it
can.
as they rise, they continue to rise, or there could be fluctuations?
I have seen it fluctuate. I have seen FSHs in the 50s and they came down. But once I see it in the 50s, and even if it came down, I still have never seen those patients pregnant. So I do feel reassured if I get an FSH level in the 50 range, that even if I probably would never repeat it again, to be honest with you. But if she came to me and said, oh, my other doctor repeated it and now it's 32, I still would not feel worried that she would get pregnant.
Okay. If somebody has irregular cycles, longer cycles without heavy bleeding, that
Yeah.
means they're irregular, they last
yeah.
longer, but there's no heavy bleeding. Do they need to be checked out?
Not for your general like polycystic, or somebody who has. I have women that have an established irregular cycle. Some people walk into my office and say, I get 4 periods a year. That's me. That's how I function. That's fine. Someone says I bleed 3 days and then I get 3 weeks until the next period and another 3 days. That's her normal. For her normal, that's okay. The only thing with PCOS, you hear that a lot, polycystic ovary syndrome, or this hormonal imbalance, I want to see those patients because I want to, I worry about sometimes some of them develop diabetes early, and I see if they have hair growth and it's uncomfortable. Sometimes we check their testosterone levels. We put them on certain birth control pills that help them. We talk about their diets, and unfortunately those patients have to work a little harder on other things like diet, exercise, and worrying about getting diabetes and things like that, and even getting pregnant because their cycles are irregular, so they're not really ovulating like everybody else.
Okay, what age should young women start getting mammograms?
So that's a good question. 40 is now about the average age. So the problem with 40, there's good and bad in getting mammograms in your 40s. The problem with 40s is your breasts are dense. What do I mean by that? If you're standing outside and looking at the stop sign down the street on a foggy day, as opposed to a clear day, dense, not so dense. So as one gets older, the breasts tend to get less dense. So we find things much quicker and easier. The problem in the 40s is we're biopsying so many patients because we can't really see, but we think, and we're not sure. But the other problem, the flip side, is if we find something, younger women tend to have a little bit more aggressive disease. So we want to really catch those processes rather early. So really 40 should be the first time, unless again, there's a family history or a genetic reason to do it. And I would encourage people who, if they have a family history of someone getting breast cancer at a young age, to definitely consider genetic testing, the BRCA, you might have heard of BRCA testing, the BRCA testing, especially in the Ashkenazi Jewish population. That is not an uncommon thing. So we offer that testing in our office. That testing does come with some issues. I mean, people who are applying for life insurance, for example, they don't want to really start testing genetic things that are not really, all of a sudden finding things out that if you understand what I'm saying, it's not so comfortable to tell a 28-year-old you're BRCA positive and now she's just beginning her life, really, you know what I mean? So it's but you do want to know, because at a certain age, and generally 30, 35, because we do much more aggressive testing for patients who have a genetic predisposition to breast cancer. But 40, short answer to your question, is 40 years old is the beginning.
Okay, there are a few questions here about getting pregnant in the 40s.
Yes.
One second, you spoke about it before, but because coming from our community, it's a very individual, personal, private question, both medically and halakhically and hashkafically and emotionally. We will not address this in public. You're welcome to interview whatever doctor you have personally and make a personal decision with your Rav. So all those questions are not going to be discussed publicly. I apologize about that. Can you please share where you practice, location, phone number?
So we practice in Crown Heights, 348 Albany, between Union and President. We practice in Borough Park and 5724 New Utrecht. That's 58th in New Utrecht and Borough Park, and in Williamsburg on 685 Myrtle Avenue. And our main phone number is 718-436-0100. We also actually, I think we have, so I will share with you, we do have an email. So people want to, sometimes people like to just send us an email, sometimes questions and things like that. I will give you that information, but there is an office. Rob, I don't know if you have that.
Okay, as we wait, Dr. Klinger, maybe. So again, this is again a question, I guess, for more clarity. This woman says, I've been pregnant and nursing and constantly. I'm age 35. How would I even know what's normal or not normal to get worried about my bleeding situation?
What do you, I don't understand the
She
question.
was always pregnant or nursing. She never even had regular cycle.
Right, right.
So how would she even know to be concerned that something is irregular? She never was regular in the first
Right,
place.
right, right.
Right. I mean, so if she's continues to be irregular, she's irregular. I mean, if there's an abnormal pattern in the bleeding. So if you have your period and if it comes sooner, to me, she's 35 years old, she has her period, she's bleeding 2 weeks later. That's clearly abnormal. That needs an evaluation. If she goes 3 months and doesn't get a period and there's no bleeding in between or anything like that, and she's been irregular previously, I don't have a problem with that.
Okay. Can someone get pregnant caused by a shock after menopause, like a sudden death? Can a shock introduce a period
No,
after menopause?
no, I don't think so.
Now, after menopause, that's very unlikely. Very unlikely.
Here it says in Canada, they start mammogram at age 50. Is that still your recommendation?
So I'll
No.
tell you about that. That goes back, and it depends actually, even in this country, who you go by. Do you go by, do you go by ACOG? Do you go by the,
Different organizations.
different organizations? I would say, from my experience of almost 30 years, that, and it leads to what Dr. Dori is saying, the younger woman who's going to get breast cancer is at the highest risk, because those are most aggressive breast cancers. So in my opinion, I would start at age 40, and I would do it yearly. I have seen patients have a mammogram at 40 and not show up for another 3 years, and there's a breast cancer there. Yeah. Nobody, well, I shouldn't say nobody, but in general, of the screening modalities we have for the gynecologic cancers, and the two bad ones that would affect our community, which is ovarian and breast cancer. Breast cancer, we have great screening for. Okay, if a woman gets a mammogram, okay, and a breast sonogram, if indicated, at the regular scheduled intervals, in all likelihood, that woman is not going to die from breast cancer. Okay, those screening modalities, in addition to a breast self-exam and an exam yearly by the physician, that woman, she may get breast cancer. It's possible. We have such a high risk in Ashkenazi Jewish women, but she's not going to die from it. And the treatments are good and the surveillance is good. So I would not go by that 50. I think, and when they make those recommendations, I want you to understand how they make those recommendations. They make those recommendations are, how many mammograms, remember, Canada, socialized medicine, how many mammograms do we need to do to save one life? Well, you know what? If you're that one person, you need that mammogram.
Yes.
So it's not dangerous. There's little radiation risk from mammogram, very, very little radiation risk. The new mammography machines, some of my older patients say, oh, it's painful, whatever. The new machines are better. It's not painful. It should be done. And I believe in starting at age 40.
I want to just add one other thing to that. Where you do your mammogram is also very important. We like breast centers, because if you just go to a mom and pop radiology place, you're not going to find a radiologist that, number one, will follow through on an abnormal result. And I encourage people, when you do a test, like especially a mammogram, to make sure to make it your business to get the answers to the results. Don't assume that no news is good news. Should always call. Usually nowadays, places will send you a letter saying your mammogram was normal. We'll see you back in a year. If you do not hear from them if you did not get that, I encourage everybody, when you do your mammogram, to get that, to get your results, and also to do it at a reputable breast center. We, for example, in our office, we recommend places that we have worked with for years. We have a very good rapport with the radiologists, and we're comfortable with where those places will do a mammogram. So just going to a place is not always going to guarantee you're going to get the best study.
Okay, so first of all, I just want to remind everybody this session is recorded and it will be posted tomorrow or by the next day. You could always listen to it on our various platforms. So no worries about that. Back to Dr. Klinger. In Canada, if you want a mammogram before age 50, you got to pay for it. You
Right.
think it's worth the
That's
money.
what it's all about. Yeah.
Exactly. All these recommendations are based on statistics.
Exactly.
And actuary. You got a bunch of numbers crunchers. They are calculating, how much is it going to cost us to do all the mammograms from 40 to 50? How many lives are we going to save? I mean,
okay. I'm 41 and I just gave birth and I was not told about getting a mammogram. Does being pregnant or postpartum affect this recommendation? Or can I get a mammogram when I'm breastfeeding or pregnant?
So mammogram, they generally don't like to do the mammos when they're breastfeeding because of the
Density of the breast. Yeah.
the density of the breast and all the tissue. So if a mass is suspected in the breastfeeding period, the best test to do is a breast ultrasound, right? So if there's a mass that seems not what should be there, I would do an ultrasound. The other thing is you can do an MRI in breastfeeding women. I had someone recently who they were concerned about, and we ended up doing an MRI in her in the breastfeeding period. There's no radiation. It's I think though there are some recommendations as what to maybe to discard some of the breast milk afterwards if they use the gadolinium contrast that they use for MRIs, but you can do it. Again, breastfeeding is not a contraindication to evaluation of the breast. And, we have our patients who are in their 40s who will be breastfeeding, for 18 months, 16 months, however long, and then boom, another pregnancy. So I really would not encourage avoiding, imaging if necessary. And, a lot of times an ultrasound will be helpful, sometimes an MRI in a higher risk patient. And
And
so
I'll
discuss it with your doctor. Discuss it with your doctor.
Yeah,
Don't just ignore it.
But also, if when in doubt, radiologists even recommend even sticking a little needle in. I know it sounds very painful, but that does give a lot of information. So there are a lot of things that can be done that need to be done. And please do not ignore any lumps. If you're nursing or pregnant, they do have to be evaluated.
Okay. I think we went through this again, but maybe this woman needs a little more clarity. I'm 52, heavy bleeding monthly. I guess for her, it's not normal. So again, it should be evaluated, but she said it was a normal age for menopause. My mother ended up bleeding heavily and having a hysterectomy. I mean, nowadays, I don't think we run right away to hysterectomies anyways. Why is that a change?
Why is it change?
Why don't you just get rid of your uterus?
Because like everything in life, there's always another side effect to it. So listen, surgery. So your risk of anesthesia, your risk of complications during surgery. And I have to tell you, so you're trading off one thing. You're generally going to stop bleeding anyway. So why are you going to subjecting yourself to surgery when you're already going to stop bleeding shortly? Unless you're high risk for developing cancer. If you told me, for example, that you did a biopsy and it showed something what we call hyperplasia, which is a precursor to something potentially bad, I might talk to you about a hysterectomy. If I knew you had humongous fibroids that you can't really breathe properly, you can't walk straight, we'll talk a different topic. But if you're 52 and you're just bleeding abnormal, bleeding heavy, and it's annoying, listen, you could theoretically go the hysterectomy route. I really don't encourage people to do surgeries unless they're really, again, it's a risk benefit thing. Do you want to take that risk of surgery for something that you may not gain that much benefit? You're probably better off just leaving it alone.
Yeah, if you remove the uterus, for example, how does it affect your other organs?
So we actually nowadays we like to remove, not only if we're going to do surgery, we like to remove your tubes and ovaries, because theoretically we also want to remove those potential cancer areas of cancer in organs that you don't really need. So if you're 52, we generally don't just do a hysterectomy. We do everything. We take the uterus, the ovaries, the tubes, because we want to, you don't need them, and you have a chance of developing cancer then. So it begs the question, so why doesn't everybody just go through that? So this way, why do I need those? But again, it's surgery, and surgery has its complications, and there's scar tissues and, and prolapse of the vaginal cuff and infections and all that other stuff. So
And
those
bladder
are
issues, no? Isn't there also
a
like
lot of
issues?
bladder issues, a lot, and that's a whole nother topic. The urogynecology field there's a whole nother, and I have to tell you, in our hospital, we have two amazing, and I'm not just not a pitch for my hospital. There are very good urogynecologists all over the place, but we happen to have very amazing, and it's very hard because I will tell you, if you have urinary symptoms, please be careful who you go to. A general urologist generally deals with male problems and will have no idea what to do for you. So if you have urinary symptoms, first thing is to rule out a urinary tract infection. Anybody can do that for your GP or anybody, but then you really want to get evaluated by a urogynecologist, which is a gynecologist who specializes in the urinary system. Female
Okay,
urinary. Yep.
so if there's no mass, should someone get routine mammograms while they're breastfeeding?
Absolutely not. If there are no mass and there's no suspicion, I tell people to at least wait 6 months after breastfeeding before they get. So if she's 42, she just had a baby, she's nursing, I would say when you're finished nursing, wait 6 months and get your mammogram.
Okay, there's another questions about getting pregnant in the 40s, but we said that's a very individual question. Speak to your
Yes.
own doctor about your own risk factors and to your own ROV, and we're not going to discuss this in public. So I think these are the end of the questions that I got. I don't know if you had any questions in your personal chat, and we want to give you a chance to wrap it up. If you want to give another message to our community, don't forget, this is actually broadcast throughout the world. Our podcasts are listened by women of all communities, all stages in life, for curiosity, and all over the world as well. But if you want to use the opportunity to give a message for our community here, we'll give you a minute or two for that as well as for any closing remarks.
So thank you for inviting us for this. I think this is a very important topic. As I said earlier, it's underrepresented in the medical community, and it is very important. It's a lot of what you heard tonight. You have to individualize, as Sarah has said, with your doctor conversation you have. But we wanted to give you some insight as to what to expect when you see the doctor, and when to see the doctor for certain things. So you have to find somebody. And if you find that your doctor's not really interested in talking to you about the menopause, maybe find somebody who is. You know what I mean? Because you'll find that sometimes doctors, if they're too busy in obstetrics or they're too busy in whatever things, they sometimes just gynecological surgery, they have no time to talk to you about your hot flashes or your abnormal bleeding. That may not be the doctor to really treat you for that particular thing. Nothing's wrong with that. Maybe they're very good at what they do, but they're not so good at this part of it. So find the one that really is good, and be aware of the screening tests. In it, at the end of the day, I tell people, diet and exercise will lead to a healther life.
How about putting Hashem back in the picture?
And Hashem always. That's a given.
Resist.
That's a given. And and basically, that's it. And genetics is one thing we can't control for, but at least the other things that we can control for, we have things to do for it.
Another few questions came in. Can fibroids affect a woman's pregnancy and cause her to have a miscarriage if it grows? Chas v'shalom.
Yes, fibroids, as I mentioned earlier, if they're very big, their location, the size, all matters. So you can have multiple fibroids that have no effect. You have one fibroid that could be pretty disastrous. So location of the fibroids and size can, yes.
Again, if someone has endometriosis and fibroids and irregular cycles, what can she do?
Medication.
She's on meds and she's 46. I guess.
I mean, the treatment of endometriosis really depends on where a woman is in her life, in her reproductive life, and so forth. The 30-year-old with endometriosis who has no children but may benefit from one type of therapy. The 44-year-old woman who has her family already and may not opposed to being pregnant, but it's not a fertility issue specifically. The treatment is very different. So you need to tailor your treatment specifically for endometriosis to what the patient wants and needs at that time.
Mm-hmm. Is it normal to have some milk leaking after nursing many years?
Sure.
For a woman who's almost 50 and just stopped nursing, do I have to be concerned about milk leaking still for my breasts?
No, I mean, if you're 50 and you've had a couple of kids along the way there, the factory that produced all of that good, breast milk over the years still exists, and there's still some leakage there. If it's bothersome, sometimes if it's a lot, and certainly, so if it looks like milk, it's bilateral, it's not bloody, it's something that it is what it is, so not stimulating manually the nipples will avoid that. A tight bra, ice packs to make it go away if they want, if it's bothersome. We don't give any medications for it or anything like that, but it's not a pathological condition for it to still exist. I mean, there are some times where women have what's called galactorrhea, which can be caused by a pituitary process, a glandular process. Again, if they're very concerned about it and we think it's, not what it most commonly is, just residual breast milk, we can do a blood test for that process. But I can tell you, if it's due to hormonal change in the brain, a prolactin thing, the milk comes shooting out. It's not just a little bit; it's shooting out.
And I also tell people.
One second.
I also,
So then describe when it would be a problem. It's not clear from this question.
Sure.
When it's excessive,
bloody,
yes.
bloody. If there's blood, that's a concern. Okay. It's not a concern if it looks like regular breast milk.
And also, I tell people to stop touching. What happens is they get scared, so they get milk, and then they keep pressing because they want to see if it'll stop. But the more you stimulate it, the more it's going to keep coming out. So don't touch. Kick nish, don't touch.
And okay, when should somebody? Okay, you said it was bloody. Okay, another question. I'm age 41 with no kids for 7 years doing fertility treatments. I got pregnant once, but had a miscarriage due to fibroids, according to the doctor. But doctors didn't want to remove the fibroid because it could affect chances of getting pregnant. Would you recommend the same thing? I guess you have to ask the doctor.
I think that's a very specific case, and there are a lot of missing details there. Yeah. If whoever had that question, if you'd like to discuss it, you definitely reach out to us individually or come for a visit. But that's a very, very specific case.
There's another question here. Just that online there's statistics. How many C-sections per. Are you running to do C-sections for, per how many births? Is there like a hysterectomy also record? Like there seems like certain doctors are like much more pushing hysterectomies rather than finding solutions to keep your uterus.
I'll be honest with you.
Records anywhere? Yeah.
Again, if we talk about procedures, I mean, last time this was compiled, I mean, hysterectomy is one of the most common procedures done in the United States. I think you're right. I mean, there are a lot of hysterectomies that are done, and I think a lot of hysterectomies that get done could have been managed other ways, medically. I think you gotta get a second opinion. If someone recommends a hysterectomy, go for a second opinion.
Absolutely.
I always, and I think Dr. Dori, we train very, very similar. When someone comes to me, I always start from the perspective is this person doesn't need surgery.
Correct.
That's how I start. And if I end up at the end with a conclusion of, yeah, that person needs surgery, I'll say so. But we both, our tendency is to be more, exhaust the medical and right. The lesser surgical interventions.
Okay, we discussed about heavy bleeding and irregular bleeding. Can you talk about bleeding before the actual period starts? Is that also very common going through menopause? Such a symptom?
Yes. So a lot of times people will tell us that all of a sudden, a week before my period, I start staining, and then all of a sudden I get my period. That's a tricky one, but that's the one where I had mentioned, it's still to me considered irregular, and I still would love to see a negative biopsy because that's a change. I just want to know that there are no abnormal cells or any other process going on that I need to address, like a polyp that we mentioned earlier and things like that. And a sono, what we do, again, that workup just for that. But it is very common, and it fell into that. Remember, we said that group that we did that full evaluation, and everything was Baruch Hashem fine, and we will live happily ever after. But we're looking for anybody who's not falling into that majority.
Well, what can I do about cervical erosion causes bleeding before my periods?
That's a good one. That's a tough one. That's a tough one. Sometimes we ablate the cervix. We use a little silver nitrate on it. We used to use something Rob remembers, AminoServe, and we used to use the medicine. We don't use that anymore.
But I'll be honest with you on that question. So I would be, that to me is a diagnosis of exclusion. In other words, I would rule out any other potential causes. So a little bleeding that, is suspected from cervical erosion, except for like that, that is a very inconvenient for our Jewish, Orthodox Jewish lifestyle, but it is not a health danger. I would rule out any, as Dr. Dori mentioned, any organic pathology before I attribute it to that. And then we can work on, topical cautery agents and things like that, whatever. But it certainly requires a more detailed evaluation.
That means going to a bodekis, and she said, it's only from your cervix, just ignore it. As doctors, you don't recommend ignoring anything like that.
You know what? I'm going to tell you. I think the bodekis is a very good thing. And I can't tell you how many times I've been in my Williamsburg office and my patient will come in. I went to the bodekis and she told me I have a polyp. And you know what? She's right. She's got a polyp on the cervix. But that's because she made an assessment and found a positive finding, right? Okay. It's different from the perspective of you want to rule out. So it's fine. Let her say that it is the cause. But if you're over 35 and certainly over 40, if you have any, and again, the two risk factors for endometrial, okay, is hypertension, diabetes, and of course, obesity, okay? With those three patients, it's biopsy before attributing it to anything else. Do a biopsy.
I think we better close up shop before we have nightmares about our health. So let's end up with something positive. Maybe do
I'm just going to say that there were a couple more questions. I don't know if you want to.
Okay, let's hear them.
I don't know. You didn't see them.
We're dismissing.
Way to prevent UTIs.
What's that?
What is the best way to prevent UTIs?
Oh, that's a good question. So emptying the bladder, especially after having relationships, would definitely help. Cranberry juice, cranberry pills tend to acidify the urine, but really emptying the bladder and not really, people who don't go to the bathroom, like people who work, for example, and it's very hard to get to a bathroom, that they tend to have a lot of UTIs. So really emptying your bladder frequently, hydrating, and cranberry pills definitely help. Some people, if they have it too many times, we also worry about, any other things with kidneys and things like that. So if they're developing kidney infections and all that, they should get a more thorough evaluation, but that's rare. Most people just fall into the, frequent UTIs, and the vaginal dryness and all that doesn't help the situation. So in the perimenopause, we do see more frequent UTIs. Wiping, obviously, I know this sounds very basic, but be careful how you wipe, because the bacteria really tend to come from that part of the body. So you want to keep them away from the urethra, which is the opening where the urine comes out.
What does it mean, cranberry pills?
So we used to tell people drink juice, but because juice is so full of sugar and everything else, so now they develop cranberry pills that you can get over the counter, and you can pop some pills. There's instructions like 1 a day or something, especially in someone who's getting frequent UTIs. I tell them to take cranberry pills. It acidifies the urine and does not make it look it does not make it appealing to bacteria.
Okay, one more interesting thing here. I read that turmeric can act like estrogen in the body. Would it be helpful for menopausal women who need estrogen? And should women to reduce estrogen after breast cancer refrain from turmeric pills?
That I don't have an opinion.
Turmeric is very big nowadays, so that's why I'll read that last one.
It's a great spice. My wife uses it a lot. I mean, I'm looking that up. I mean, I'm not really familiar with that.
But that's one we're not as familiar with. By the way, for those of you who don't, I was just realizing as I talk, for those who don't know me, I'm happy to get onto Zoom real quick. I used my son's Zoom, so the Mark Ian happens to be my son, Ezra Dori. So don't get confused with that. So if you Google Mark Ian, you're gonna find a law student. You're not gonna find
Dr. Dori.
Somebody asked for email address. Can I
Yeah,
post
oh
that?
yeah, I sent you on the chat. It's KDGT as in Klinger, Dori, Gorelick, and Sermis. K as in Kite, D as in Dori, G as in Gorelick, T as in Tom, at Northwell, NORTHWELL.edu.
Actually,
at Northwell.
I did what one of you would do as well in this situation. I consulted Dr. Google. And actually, interesting fact, actually turmeric is not recommended if trying to become pregnant, actually. It decreases, uterine endometrial health, and actually has been proposed as a natural treatments for endometriosis because of that. So
We're learning something every day.
so we learned something tonight. Thank you.
I always say teaching
It's
is
that
learning,
question.
so it's good.
Oh,
So the
wow.
phone number was 718-436-0100.
Yes, that's correct. Yeah, and the KDGT got right at northwell.edu.
I got the email address.
Okay. Thanks so much, both of you.
Thank you so much
My
to both
pleasure.
doctors
Thank
and
you
Ms.
for the
Naraza
opportunity.
for taking
Yes,
the time to do
thank
this
you
really
so
important
much.
presentation. It was so interesting and extremely informative.
Thank you.
Have a good
Good night.
Thank you so much.
Thank you. Good night, everybody. Thank you.
Good. And Dr. Dori,